Hi everyone, welcome. Today's session is on improving food through health. So if that's not the session you thought you're in, now is the time to stay and join us anyway. Um, we're going to be talking about referring eligible San Franciscans to food as medicine services that are available through Medicaid and CalAIM. Oh, there's a clicker. Cool. My name is Sophie Shobo. I'm the manager of Outreach, Enrollment, and Social Determinants of Health programs at the San Francisco Community Clinic Consortium. And for those of you that don't know, the consortium is a partnership of 12 nonprofit health centers in San Francisco. We support clinics with a lot of different things, but my job specifically focuses on supporting clinics with their programs around outreach and enrollment programs for programs like Medicaid or Healthy San Francisco, and then on our social determinants of health programs, which at the moment is largely the food as medicine programs that some of our clinics operate and also refer to, like today.
And hi, everyone. My name is Erin Franey. I'm the director of the Food as Medicine Collaborative, and we are working to make healthy food a part of healthcare by supporting a food as medicine program called Food Pharmacy at clinics in San Francisco, and also doing local and statewide policy work to operationalize and sustain food as medicine services in healthcare.
Brief agenda. So Erin and I are going to give a quick overview of medically supportive food and nutrition, what it is, why it's important for health, how it relates to Medi-Cal, and kind of the overall picture of what it looks like in San Francisco today. Then we're going to spend the majority of our time having a moderated panel discussion with our lovely panelists here, who you will meet in a little bit. And then we're hoping to have a good amount of time at the end for a Q&A from all of you. So if you think of a question, write it down, and then you'll have time to ask it at the end. So before we get into this, I just see a show of hands. Who here knows what medically supportive food and nutrition is? Okay, cool. And who here works for an organization that is contracted with either San Francisco Health Plan or Anthem to provide these through Medi-Cal? Awesome, that table over there. And who here has referred to these services within Medi-Cal, referred somebody? No? Okay, awesome. Well, you're here to learn how to do that, so that's great. Okay, so you all are pretty familiar, so I'll go through this quickly. Medically supportive food and nutrition, or MSFNN, or food as medicine, or food as medicine, all refer to a spectrum of interventions that are designed to address diet-related health conditions through access to nutritionally appropriate foods. So there's a lot of different kinds of services within these buckets, but there's sort of two main categories. One is medically tailored and one is medically supportive. Medically tailored meals or groceries means that somebody is receiving a meal or a grocery bag that has been tailored to a specific condition. So a registered dietitian has looked at that meal and said, this is nutritionally appropriate for somebody with diabetes if they have a diagnosis of diabetes, or renal disease if they have diagnosis of renal disease. Medically supportive means that the food is generally healthy. It meets the dietary guidelines for Americans, and it's generally going to be supportive of anybody with a condition, a nutritionally related condition. And then ideally, any of these services are paired with behavioral interventions, cooking classes, or nutrition education. So why is this important? Diet-related chronic diseases are a leading cause of death in the United States. Huge problem. Over 9 in 10 adults have, in the US, have suboptimal cardiometabolic health, and 6 in 10 have at least one chronic disease. So we need lots of different ways to address these issues that we're seeing, and MSFNN is one of those ways. So research has found that these programs can help reduce blood sugar, reduce blood pressure, reduce ER visits and admissions. And data from the Department of Healthcare Services in California, DHCS, has found that for the programs we're talking about today in the state as a whole, they have shown to reduce costs for both inpatient and outpatient services, as well as per member per month emergency room costs.
So what is the status of these services in Medi-Cal? So Sophie mentioned CalAIM, that is California's state Medicaid waiver, And CalAIM is broadly working to more directly address patients' health-related social needs. So as part of that, there are 15 approved community supports, and one of those 15 is medically supportive food and nutrition. In Medi-Cal or in CalAIM, it's called medically tailored meals / medically supportive food, so like MTM / MSF. And all of these 15 community supports, things that are important to know about them, these are optional services, which means that Medi-Cal managed care plans like San Francisco Health Plan and Anthem can choose to offer them to their members, but they're not required to. And CalAIM is a demonstration pilot project, essentially. And so the waiver started in January of 2022 and expires at the end of this calendar year. And we're excited to share that over the course of CalAIM, medically supportive food and nutrition services have been the most utilized of these 15 community supports. This past year, almost 200,000 Californians access medically supportive food and nutrition services through Medi-Cal. So you may be thinking, wait a second, Erin, this waiver expires at the end of this year. What's going to happen next? It's a great question. So the Department of Healthcare Services, or DHCS, they are planning to renew the CalAIM waiver with the federal government. This is a little wonky, but I want to share it because it may come up. So medically supportive food and nutrition services, as well as 11 other community supports, have existed inside of CalAIM. They also exist in their own federal authority called In Lieu of Services, or ILOS. And so DHCS has said that their intention is that these 12 community supports are actually not going to exist in the renewed CalAIM waiver. They're just going to keep living in ILOS. And what that means sort of for all of us in the room is that these services remain optional. But there's no expiration on them. So it's not that there's some date and then they could go away. In theory, as long as the state and the federal government continue to approve them, they'll be available to folks in California. And then the legislature has also made some plans as the end of CalAIM is approaching. So Assemblymember Mia Bonta, who is a huge champion of this work in California, she has introduced legislation to broadly support the continuation of community supports, and that's AB Assembly Bill 2348. And we can talk about that more in the Q&A if folks are interested. And then statewide, the Medically Supportive Food and Nutrition Coalition, which is co-led by Full Well and the Food is Medicine Collaborative. We've also worked with Assemblymember Mia Bonta to introduce a resolution that's just generally calling for the sustained implementation. Oh, sorry, thank you. Yes. So what is available in San Francisco today? So 3 of the services that Sophie mentioned are available: medically tailored meals, medically supportive groceries, and produce prescriptions. Oh yeah, so thank you. And so medically tailored meals, it's 2 meals a day. And as Sophie mentioned, a member would be required to have an assessment with a registered dietitian nutritionist as part of that and be offered medical nutrition therapy. Medically supportive groceries. One thing I want to point out, there's no minimum requirement for the quantity of groceries that are provided with medically supportive groceries or the variety. You can generally expect a mix of produce, grains, and protein. And there's a range of nutrition supports that are provided as part of medically supportive groceries. It can include medical nutrition therapy like medically tailored meals, but it could also be kind of more general cooking and nutrition classes. And then produce prescriptions, which are typically a card or a voucher to purchase fruits and vegetables. The dollar amount, as far as we know, can vary between the different providers of these services. And similar to medically supportive groceries, there's kind of a range of nutrition education that's associated with them. And one thing to just emphasize, so these services are available today in San Francisco. Anyone in this room could refer someone to these services, which we're going to talk more about, but just really want to highlight that this is available to Medi-Cal members who are eligible. And to help kind of inspire and support everyone in the city to be referring folks to these services, the San Francisco Community Clinic Consortium, the Food is Medicine Collaborative, and some other organizations have come together to try to put on a single piece of paper a chart that just outlines who are the organizations that are contracted with San Francisco Health Plan and with Anthem to provide these services, and what are kind of more of the details of what they offer. We are going to be passing this out now. I realize it's very difficult to see on this slide. It was more just to show you kind of what it looks like. And you'll notice when you see when you actually get the pieces of paper, there's a little bit of information that says kind of like to be announced. We are finalizing a few of the details on this chart. This is the first time we're disseminating this publicly, and once we finalize these last few providers, we'll do a more kind of formal dissemination, but we are excited to share this resource with you all here today. And with that, I am really excited to introduce our panelists. We have Shantessa Clark, who is the Manager of Enhanced Care Management and Community Supports at San Francisco Health Plan. We have Alana Pfeffinger, who is the Regional Program Manager at Anthem Blue Cross. Ashley Mars, who is a phlebotomist and patient at Castro Mission Health Center. And Maria Gutierrez, who is a registered dietitian nutritionist at the San Francisco Department of Public Health. I am now going to pass it to Alana and Tessa, who are each going to give a brief overview of the referral process. The other papers that Mia and Stephanie are passing out are the referral forms for San Francisco Health Plan and Anthem, so you all will have those in front of you. And they're just going to share a little bit more about kind of data around these services in San Francisco and how to refer someone. So I will pass it to you both, and you're welcome to either come up here or stay there, whatever you prefer.
Who's up first? Okay.
Oh yeah, Tessa, you're
You're
first.
Tessa.
Okay.
You're up here.
Okay, sorry. I try, because she does it so much better than I do. So for,
Do this, or I can stand there too.
Thank
This is
you.
to move the slides. You can also stand up there.
yeah, no worries, I've got it. Maybe. Maybe I have to? This one? Thank you. Hi, sweetie. I got the lucky chair. I get to sit next to the fur babies.
Yep.
Nice. So just a little bit about SFHP, San Francisco Health Plan, and some data on what we currently have as far as enrollment for our membership in medically tailored meals and supportive foods. As of the beginning of this month or end of February, we have authorized 1,058 unique members. So that's 1,058 lives that have been offered 12 weeks worth of supportive foods to help improve their chronic conditions. Of those 1,058 unique authorizations, I misspoke, there are 1,011 members. So 1,058 is how many authorizations we've done. So that means some of these members have been approved more than once. So what we do is we authorize up to 12 weeks for the initial referral. And if the dietitian or staff at the supportive foods provider feels that the member would benefit from an additional authorization of 12 more weeks, we will do a little bit of a clinical review and then approve or deny based on the documentation that's provided to us. SFHP specifically will authorize up to 1 year if deemed medically necessary and we're seeing improvements and changes in the members' health and behaviors and engagement in, making their own meals or choosing healthier options. We do have a fairly small provider network of 6 MTM providers. We are actually also in process of contracting with one more provider who acts as a hub model. So they have subcontractors that provide the services under their kind of leadership. So we will have a provider network that offers hot meals, frozen, shelf-stable, culturally appropriate, refrigerated, and groceries as well as vouchers. So we try to see this program as a step down where a member who may not be able to cook their own food, they're getting delivered prepared meals, right? And at some point maybe they are able to cook, we'll go with groceries and give them healthy options. The nutritionist will do those things where they can help them pick recipes. And then eventually if the member is able to shop for themselves, it gives them the autonomy to kind of keep on that diet but being able to choose those products for themselves. So essentially they could do 36 weeks if they do each renewal within each setting. So that's kind of how our program works. This is a list of our provider network. So each provider, we've listed kind of what they offer. Meals on Wheels, we are ending contracts, but the rest of the providers are actively open and accepting referrals from any entity. So you could be a member's caregiver, a primary care physician, an ECM provider, CS provider, or the members can also self-refer. So we have a no wrong door process. They can be referred through calling our intake line, filling out a referral form and faxing it in or emailing it in, all sorts of different options. And that's that slide. So we do require some documentation, however, when we do receive the referrals, just to confirm that the member has a condition that would benefit from whether it's groceries or meals. We review that and we let you know as the referent if that's been approved. We also inform the referent of who the provider is so you can follow up with them to ensure that the member is being connected. We very rarely will deny. I think we can go to the next slide. No, okay, I missed it. Very rarely will we deny, but we might if the renewal has been asked and we just don't have enough supporting documentation for that. We may ask for more information just to kind of help, but having the RDs really involved in the members' services and having them do the nutrition counseling is helpful because that supporting documentation is there kind of organically. Hi. And so then, you know, we're happy to work with our providers on ensuring that the members get those services. Additionally, if you cannot find our referral form because it's buried in the website somewhere, we also will accept Anthem's referral form or Kaiser's. So please do not be afraid to fill out a random form and send it to us. As long as we have the members' information and they're active with SFHP, we'll be happy to review it.
Awesome. I'm going to stand up just because it's a little easier for me. But hi, everybody. Alana Peffinger, a regional program manager with Anthem Blue Cross. So wanted to kind of highlight what the landscape looks like right now. This is actually 1 year ago. We have some of our information as far as number of unique authorizations, which is on the smaller side. As well as the number of individuals receiving. So similar to what Tessa was mentioning, because an individual can be reauthorized to receive services, sometimes there's a difference between the number of individual folks who receive services versus the number of total authorizations. Similar as far as the number of providers, we currently have 6. I will say I did pull some updated data, and we did have about 171 individuals who ultimately did receive services in 2025. And right now we're on target to increase total utilization by about 43% this year, but I'm very hopeful that as we are getting some additional providers into the network, we'll be able to increase those numbers overall. Just kind of want to talk about the ethos for Anthem as we're looking to build out our networks. Really critical is having local providers in our network, so that's kind of been our priority as we've looked at different expansion opportunities to really focus on local providers. Keeping me moving, thank you. And then here's the list of our current providers. So very similar to what Tessa was mentioning, we do have some overlap in our provider network, which is great. And then we're also collaborating on the Partners in Care Foundation, which will bring a multitude of interventions underneath one umbrella. Next slide. So what is needed for a successful referral? Really important to point out is because knowing that there's some providers in the room who may be super agnostic when it comes to if an individual is enrolled in managed Medi-Cal. In order to take advantage of these services, an individual needs to be actively enrolled in managed Medi-Cal, either with Anthem or San Francisco Health Plan or Kaiser. So that's the first thing, really kind of the most important thing for referring an individual, is that they have active Medi-Cal. We need the member's information. We need the referring entity's information. And then we need you to check the box as far as the different type of services that a member is interested in receiving. Do they want medically tailored meals? Do they want vouchers? Do they want prescriptions? You can indicate that on the referral form. We actually do not require documentation. We do encourage it just to speed up the referral process, but our team is able to have access to patient information to verify that they have a qualifying condition. And then really just wanted to highlight common reasons for denial. So as I mentioned previously, not having active Medi-Cal with Anthem. Sometimes they're already receiving some type of services from another provider. We sometimes get more than one referral, so maybe a social worker and the member are both referring in for the service. And then finally, member does not meet eligibility criteria. Important to note that specific to this program, it's for individuals with a nutritionally sensitive condition. It's not meant to treat food insecurity. That's it.
Awesome. Is this still, yeah. Thank you. I'm going to just unplug this to turn off the slides.
Perfect. And then
So now we're going to talk. Okay, so we're going to go into a few questions from Erin and I, and then get to all of your questions. So, first question, I'm going to just I'll ask all of you sort of a question just related to like your general experience of this program, how it's been going, what's been working well, what are the challenges, and I would love to start with Ashley. So Ashley, could you share a little bit about what service you've received, how long you had it, what you liked, what could have been improved, and how it impacted your health?
Hello, everybody. My name is Ashley. I'm a mobile phlebotomist out here in San Francisco and the surrounding Bay Areas. I'm also been a patient of Castro Mission since I was 21, 22, 38 now. They're basically my family. I've been there for years, and also watching what they do just further entertained my want and desire to get into the medical field. So that helped a lot too. The services that I have gotten are speaking with a nutritionist at Castro Mission. Her name is Christina. This is my second round working with her. I am a Crohn's patient. I've had Crohn's disease for the last 11 years. I'm sure a lot of you know what that is. If you don't, or completely don't have an understanding, feel free to ask questions. I'm completely transparent about it. But in the last year, things got really bad because my body started rejecting medicine. And so I had to get put on a new medication, but that was not aware by my GI doctor, even though my wheels keep turning because I'm also a medical professional. But basically, my body was rejecting my medicine. I got put on a new medicine in May, Skyrizi. By the grace of God, it is working. So I went from like 90 ER visits to I'm only at 8 this year so far. So big difference. But with that being said, I found it through Instagram, Mom's Meals. And they're absolutely amazing. I want everybody to start recommending them to their patients and their clients, because one thing that Mom's Meals has told me is we don't have a lot of San Francisco clients, which is unfortunate because the city is huge on resources. If it wasn't for San Francisco, I wouldn't have a foundation that I have under my feet today. I was homeless. I was in Job Corps, homeless again. We lived in SROs. I have my own permanent apartment now. It's been a challenge, but I've been working the systems that are that work for me here in San Francisco, and to see something like that not as well known is a little frustrating. And because my nutritionist told me that they're potentially fighting to make sure that that program doesn't end at the end of this year. which even puts an even more frustrating cap on that, because I live in an apartment building with 99 units that was originally demographed for seniors and disabled people and has recently opened to families. Everybody in my building would be able to benefit from that program. We get groceries delivered to our building a couple times a week, but that is stuff that is about to be expired or expiring that day from Trader Joe's. And people like me, who's autoimmune, I'm not going to pick something that's expiring that day or within a day, because that could potentially upset my stomach. So getting mom's meals and more programs like this around the city and more well known would be amazing. I used to get the vouchers from my nutritionist, and the only other thing I would say is, when we go to doctor's offices, our doctor's offices treat everything through our insurance, right? We don't just single out eyes or, throat or whatever. So with insurance, it shouldn't allow us to only be able to utilize one of those programs. Because I'm doing mom's meals, I can't get the vouchers anymore. And if insurance is going to pay for it, why single out what I can utilize if it's going to be paid by insurance? It should be able to be accessed by everything. Yeah, that's about it. Any other questions?
Thank you. I think next, Maria, would you mind sharing what your experience has been referring CalAIM patients, or Medi-Cal patients to these services? What's worked well or been challenging?
Yeah, hello everybody. I am Maria Gutierrez and I work as a registered dietitian nutritionist for the San Francisco Department of Public Health. It's been wonderful, and I say that because I've been in the field for quite a long time. I'm not going to say my age, but quite a long time, enough to feel the frustration of having to tell patients who are experiencing the social determinants of health, like food insecurity, that they could benefit from fiber-rich foods, but they are not having the access to get these foods. And so having the ability to refer patients to the services allows me to feel like my job is more meaningful, but for the patients especially, it allows them to put the dietary recommendations into practice, and that is really important. I also feel like it's given them a sense of dignity because they have choices within this program. They can choose frozen meals or hot meals. I know my Latino patients prefer a bag of groceries. They enjoy cooking their own meals, and some patients want the veggie vouchers to go to particular stores and get their groceries. So it's given them self-confidence, it's given them autonomy, it's given them choices, and we've seen results in their blood pressure. We've seen results in their hemoglobin A1C or the average sugar tests because they've incorporated these dietary recommendations of eating more fiber-rich foods.
You. Can you share a little bit about, like, you said a little bit about the benefits that this has shown in your patients. Would you mind sharing, like, maybe a story of a specific patient and how it's benefited their health?
So I have two stories actually. One that I was very, very excited to hear is a patient who has a behavioral health condition. This program allows us to refer patients who have, for example, major depression. And so this patient came to nutrition because they were underweight. And when I would refer the patient to a congregate site to get a meal, the person couldn't make it because they didn't have the energy to make it to the meal site, or they would fall asleep. And so this person was eating one meal a day. When we were able to refer to the MTM program, the person started eating not only 3 meals a day, but going out of the house to get snacks and have more energy to be productive in the community. And the weight came back to normal, and this happened within a period of 3 months, and the patient has remained with a normal body weight. So that's one example. Another example is how time for changes takes a little bit of patience. So I have another patient who is diabetic or has diabetes and has participated in food pharmacy 3 times. The first 2 food pharmacy cohorts didn't see much of a change in their average blood sugar levels. In fact, it would go down and then it would go up again. But on this last 3rd cohort, where she advocated to be part of it, her A1C went from 11 to 7.4. And she started off as an A1C of 14. So for people who don't know what an A1C is the average blood sugar in the last 3 months. And so 14 means your sugar is way above 300s. And so she's now hovering around close to 150s from 2023 to 2025, December 2025. So just goes to show that sometimes authorizations are necessary so that patients can reach their goals.
Thank you. Okay, I'm going to go to Tessa and Elena. I'm going to ask you the same question. Both of you can pick who goes first. Can you share a little bit about your experience offering these services and what's going well or been challenging? And have you seen any evidence of them improving the health of your members?
Thank you. And now you can start.
Great. I will start. I will say in general, as you can see in the numbers, I think there's great knowledge about medically tailored meals, medically supportive foods, and it's generally had a lot of uptake throughout the state. So that's really fantastic. I think, one of the things that's been great to see is there's been a lot of advocacy efforts from community-based organizations that, really have the knowledge around medically tailored meals, medically supportive food, how it should be offered, kind of time duration needed to really kind of see those health outcomes. And so as we spoke, that this is a demonstration program with a waiver, it's really allowed for a lot of time for kind of an improvements in how this program is delivered. And so recently we saw that in April of last year, there's more standardization around the language of who's eligible, how these services are to be delivered, so there is more equity, if you're getting food from one provider versus another. It's not kind of choose your own adventure. There's more standardization, if you will. That was a weird analogy to use. But so I think that's been super, super positive. I think one of the challenges that we've encountered, we're trying to contract with local organizations. This billing and the mechanism to kind of take advantage of these services is a little bit outside of their wheelhouse, or maybe many of the folks in this room, you might be more grant funded. So I think that's been a little bit of a challenge as far as helping organizations kind of come into the fold. But we've seen a lot of really great models that are looking to address that so that there is more local representation from local providers. And I think in general, kind of what we've seen is we have seen some really good outcomes as far as, efficacy. We talked about the data that we've seen to date. I know Anthem was participating in Food as Medicine kind of projects back in 2019. And so in general, I think we've seen a lot of really great progress. And I think, one important thing to also note is that in addition to kind of looking at it's medically tailored meals, medically supportive food, but also nutrition counseling, education is another core component of these kind of services being offered. And I think that's really fantastic to be able to offer to really kind of help people move behavior change along so that they do kind of increase the skills, knowledge, and efficacy to really manage their conditions and eventually transition off of some of these services.
So I'll start with the good stuff for sure. One of the things that our meal providers are really good at, and you mentioned Mom's Meals, also one of my favorites. All of my providers are favorites, but the providers do a really good job of not just ending the support with the members once they stop receiving meals from them, right? So for example, the 12 weeks are up and they're just like, we've been giving you meals, or your 24 weeks is up. But then also they go the extra mile. These are other resources in the community that you may benefit from outside of this community support, whether that's, local food banks or other delivery services or Meals on Wheels through the county. So continuing to support the member in understanding that this service is not just meal delivery. There's so much more that goes into it. The education is in depth. The engagement is big. Building trust with a member is difficult. I mean, you're basically cold calling somebody and saying, "Hey, I want to offer you food First, they're not going to answer the phone, because they don't know who's calling, right? I don't answer unknown numbers. So they try really hard to reach out to these members to get them engaged. And then you're delivering to their home. And there's a rapport you have to build there, trust, to allow somebody to come to your home once a week to deliver these meals, and trust that they're going to show up and be consistent. So the oversight there with our providers is just making sure that they are showing up for our membership, and they're all doing that, which is amazing. Part of the challenges, I think, for us is that they're not well known. We do forums like these, we do panels, we talk to people in the community, and yet our providers are like, we have the capacity to serve your members. SFHP currently has close to 160,000 people, and we're only serving little less than 1,100. The need is the service is there. The word needs to get out. However we can do that, we encourage our ECM providers to refer to this service. We encourage members to tell their families about it. So that continues to be the challenge, and we're going to continue to do things like this to, have advocates who speak highly of the services in the community. And the other is just, like Alana mentioned, kind of honing in on what is the criteria and making sure that these members understand that their conditions can be managed through healthy diet. Some people think, oh, I have CHF, it is what it is, right? And it's like, actually, we can help you with that. Or you're taking diabetes medication today. If you do this, it's possible 6 months down the road, you may not have to take insulin, right? So that education is key. So still lots of work to be done. The waiver is going away, but the service is not, which gives us plenty of opportunity to continue to improve the program.
Awesome. Thank you all so much. Our next sort of question topic is getting advice from you all around referrals. And for everyone in the audience, again, one of our goals here is that you all feel more equipped to be able to refer folks that you work with after this panel. So Maria, we're going to start with you. Can you talk about the supporting documentation that you provide when you're submitting the referral form? And do you have any advice for folks in the audience who might be thinking about doing this for the first time?
Yeah, so the documentation that we send is a progress note, obviously from our team, nutrition, along with the referral form. Currently, we have changed the workflow, and so the behavioral health assistants at the clinics at the clinics, they're also assisting with the referrals. And so some of them call the plan themselves and enroll the patients. And then some of them take our note and send it via fax. I think the biggest advice would be to identify champions within your organization who are willing to take this on, and maybe think about creative ways of doing this. For us, we realized that we were running out of capacity, but then we partner up with the behavioral health assistants to continue being able to support patients and refer them.
And how do you follow up if you haven't heard back about a referral you submitted? And can you also speak to just how long it takes you or maybe a behavioral health assistant to actually fill out and submit the referral form?
Yeah, so we typically have a follow-up with patients. And so at that follow-up visit, we ask them how it went with the referral. I think the challenging part is that sometimes patients are unaware of who their contact vendor is, and they don't know how to reach them should there be any issues with delivery or the ordering, or they might want to change the type of supportive food that they're receiving. Then the other challenge is the referral time. We recognize that plans have limitations, and so sometimes it could take months, like a month, or it could be as short as 2 weeks. So it really depends on what else is going on.
Wonderful. And Ashley, as you shared, you found out about this program on Instagram. Do you have any advice for folks in the audience who may be interested in these services or connecting folks to these services? Like, what advice would you have for them?
So since I found out about it through social media, my application through Mom's Meals was actually denied like 4 times because they were sending it to the wrong state of insurance. And that insurance was then coming back and saying, well, you haven't gotten service from Kaiser since 2013. I'm like, yeah, I was born there. And I literally, as an adult 22, have been on Healthy San Francisco since. And so I had to fight with them and resubmit 3 or 4 times. And then I finally got submitted and I got approved. And to go on, like Maria had said, I was 230 pounds before I got sick. Well, before my Crohn's got worse. And I dropped down to 115. Mom's Meals made it so that I got up to 147, 150. So that was really great. It is a hard process to sign up, especially if you have Mom's Meals sending your application to the wrong state's insurance. And because I'm medical also, and I've done front office, back office, I instantly was like, so that means you guys are most likely submitting through my social security number, not the number I gave you, which is my Medi-Cal number. And you're pulling up old demographics from when I was under my mother's umbrella of Medi-Cal. Please use the Medi-Cal number that I provided to you because that has my current health history till now. So we finally got it done. I had to talk with like 3 reps and have her like follow up and this, that, and the other, and it finally got put through. That process, because I have Crohn's and because at the time that this was happening, I used to cook and went from basically not being able to get out of my bed or leave my apartment half the time. And so Mom's Meals allowed me to have food in the house again, which is obviously important for our bodies in every way possible. But the process was teeth pulling. And for somebody who has an autoimmune disease where the number one thing that makes it worse is stress, I'm already at the time was stressing about finances, stressing about disability coming in. I don't need to be stressing about food. The only other thing I would say was through the process, it was fine. I got my food. I got to pick my food. They have menus online. You can build an account. You can select what you want every week. If you don't, they'll send you what you ordered previously. The first delivery is always like a chef's choice. So they just put a bunch of meals in there and you just eat them. But after that, you can pick what you want. But I will say, after the 13 weeks, I knew it was coming. And so I started asking them, how do I get renewed? How do I get renewed? How do I get renewed? And they kept telling me, we can't put it in until your last delivery, which was the February 17th. Mom's Meals sent over the information to San Francisco Health Plan. And it wasn't until literally this week that it finally got approved. I came home yesterday and there was a box in front of my door, which I was grateful for, right? But let's be real. Today is the 26th. Yesterday was the 25th. My last meal was delivered February 17th. And because the nurses who approve the documentation that is sent by Mom's Meals by the nutritionist was sitting on it, I even called in and was like, hey, can we get this? Because at this point, I have 3 meals left and you're going to starve me. A little dramatic, I understand. But sometimes you have to light that fire under them to get them to be like, oh, let's put you on the forefront. So she tried. Didn't work. Followed up with me Monday. She tried. Didn't work. And I forgot to call back. But I don't have to because the meals are in front of my door yesterday. But it should not take Healthy San Francisco over 30 days to approve documentation that has been sent to them. Sorry, he likes to growl sometimes. Don't mind him. He's a puppy. It shouldn't have been that long. If I was a cancer patient, if I was a diabetic patient, taking that long could put me in more harm's way health-wise. So if we can just get those programs just a little more finalized so that people can be more on the forefront, it would be a lot easier and less stressful.
Thank you so much for sharing, Ashley. Alana and Tessa, what advice do you have for folks in the audience about how to submit successful referrals? And particularly, I'm aware that a lot of folks in the audience may not have access to a person's health records or health information. So like particularly for folks who maybe don't have that access, how can they work with a person to ensure that they're submitting a referral that's going to be authorized?
Thank you. Based on that feedback, yeah, that's not acceptable. We are trying to work on, I was just having this conversation earlier before the panel on trying to restructure how we do referrals and how we authorize them, because the process is a very manual, tedious thing, and with the volume, it does create delays, it does slow it down. So working on better, more efficient methods for intake, and then triage as well, right? You're going to have people who are more chronically in need, but also not, dismissing the folks that have chronic conditions. that are not urgent. But I'm sorry, I'm still thinking about the fact that I am so disappointed that it took a month. I'm trying to rethink of your question.
Yeah, that's
So
I
referring
understand.
and
So
getting.
yeah, so let's say someone here is working with folks who might be on Medi-Cal, but and maybe that person is saying, oh yeah, I have diabetes, or I'm living with HIV or cancer, but they don't have a way to like pull up a medical record to show like here's the verification. What advice would you have for them about what they should do kind of to help complete the referral as much as possible?
Yeah, get a hold of our care management intake team directly. Talk to an intake coordinator, escalate that request. Those come to me. And we have the capability of looking up clinical documentation to kind of expedite that request. It's not standard practice today, but it will be in the next few months, to where we will be doing similar to what Anthem is doing, to where we may no longer need to request that supporting documentation. Also, per DHCS, we are not allowed to pend a referral just because we don't have that information. So we will process it, but it will take us time to review those documents.
Great. And Alana?
Yeah, I mean, right now, the way that it stands with Anthem's process is that we do have access to patient medical information. So we are able to, our clinical intake team will be able to see whether or not member meets qualifying criteria, which is why we indicated that the documentation, while recommended, is not required. And then if we are unable to kind of verify, we'll follow up as appropriate.
Thank you. Okay, this is our last sort of round of questions, and then we're going to get to all of your questions. I'm going to ask all of you just kind of for final thoughts as you've been listening to each other, and also your final thoughts in terms of, I'm going to ask kind of what happens when the 12 weeks is over or when the program ends. So Ashley, you just got reauthorized, which is great.
Exciting,
And I
very
think
exciting.
you've kind of talked about this a little bit, but do you want to talk at all about like what your experience was sort of getting to the end of that 12 weeks a little more?
I'm sorry, can you repeat that one more time?
Oh, do you have anything to add, or you want to talk about kind of what happened when you were getting to the end of that 12 weeks or when the program was wrapping up?
Well, since I'm a Crohn's patient, I kind of pay attention way more probably than I need to. So I was aware of the timeline, and I started asking them early because I didn't want what happened to have happened. And so I don't know if Mom's Meals maybe needs to powwow with SF Health and see like maybe they need to come up with an agreement on like you just said, at week 11 or week 10, they ask the client, are you satisfied? Would you like to continue? Do you want me to put in a second request to renew? And I mean, my brain is a medical brain. So of course I'm gonna think more than like my neighbors will who live in a wheelchair, for instance, right? So I'm proactive on my timelines and things running out because I don't want them to if it's something that I want to benefit from. But other people aren't that proactive, or they don't know that they can, or they don't have the knowledge, or they don't have the confidence to speak up like that. And so maybe if the programs can more work together so that the referral process starts sooner, the renewal process starts sooner, so that, let's say I was an 80-year-old woman, right? And my meals stopped on February 17th. I haven't had meals for over a month and a half, if I had some type of financial, anything, I would have just been out of luck. So if they could powwow, maybe that would make that transition a little bit smoother. I was lucky I found it on Instagram. I don't see Mom's Meals advertised. I've seen it a few times on TV, but it's not advertised in San Francisco, which is weird. And I think one of those, like that program specifically, should be like overly blown up on advertising, because I promise you would probably end up having all 160,000 patients that are being served in San Francisco on Mom's Meals. Because people love free food in San Francisco. People love free everything in San Francisco, but specifically food. And they don't have to leave their house, and they don't have to, They can either place the orders over the phone or through their account online. And it's just, that part is seamless, but the starting up and renewing is not. And then I also understand that because I'm a medical professional. Like, I understand billing and coding, I understand authorization codes. So yeah, just if we can get that, if they could work together just a smidget more to be able to be on the same page when it comes to that. I also want to say maybe we should look into a company called Imperfect Produce. They buy all the ugly fruit and vegetables that the grocery stores will not take because they need them to be a certain shape and a certain color and a certain shine. And if it has a little blemish, they don't want it on their shelf. So Imperfect Produce purchases that stuff from them, and then they sell it to people. They started out as fruits and vegetables, then they went to meats, dairies, non-perishables, and now I can literally buy like rose facial oil off of there if I wanted to. They give customers who have food stamps like it used to be like a 60% discount on every transaction. I think now it's like 30 or something. I don't use that benefit anymore. But I think because Imperfect Produce is literally on the other side of the water, it's like an East Bay company, that it would allow them to blow up and become like an amazing more company than they already are. But then if they could like nail down a contract with San Francisco Health Plan, then I could put my order in through Imperfect Produce and I can get a variety of stuff that I can cook on my own and stuff that I don't feel able to cook. I just pop in the microwave for mom's meals. So there's things like that I have a bunch of ideas and I wish people could team up more.
Thank you. Okay, Maria, you're up next. So, we've talked about these programs are really geared towards people with diet-related chronic conditions. They're not meant to address food insecurity. However, we also recognize a lot of patients on Medi-Cal are experiencing food insecurity along with these chronic conditions. So could you talk a little bit about what happens after one of your patients kind of finishes these services, similar to what I asked Ashley, but also do you find that because of that they're seeking additional resources? Are you able to connect them to any additional resources? And how does that go?
That's a great question. So, as part of our follow-up visits with nutrition, we ask them if they're experiencing food insecurity. And so, if they say yes, then we refer them to congregate meal sites or we refer them to local food pantries. But again, we're relying on what's available in the zip code data reside from the SF Marine Food Bank. We also refer them to community supermarkets such as the D10. And patients are always, once they've had this program, they're always interested in being connected to food resources. That just never stops. The issue here is, do the zip codes where they reside have the infrastructure to serve these patients? I wanted to say something about what Ashley mentioned. So one thing that I am trying to do with patients is to empower them and tell them, hey, once you know who your vendor is, try to bug them. When you know that it's towards the end, try to or bug us and tell us, hey, I need a new referral, so that we can make sure that you have continuity in service. I hope that answers.
Yes, that's great. Thank you. And I'm just going to put in a little comment, which is that, you also have the chart and you saw up there the chart of all the different vendors. Different ones of them will do referral or renewal assistance more directly. I would say like some of them actually do referral assistance directly that you can call their phone numbers. I don't think that's on the sheet, but some of them will do that. Yeah. Okay. Tessa and Alana. I guess first off, if there's anything you want to share in reaction to just like what you've heard or anything you want to share, let's maybe start with that. Yeah.
One, thank you greatly for the feedback. When we don't know what's going on, we can't fix it. We don't know what to fix. So greatly appreciate that. So sorry for that delay. That is not okay. I worked in GI. I know what Crohn's is. It's not fun. It's life-threatening. And you... Oh, I'm so sorry. Yeah. Yeah, and you are one of 11,000 people that we touch and probably may have other delays on that we're not aware of. So this speaks to challenges, right? Process improvement, the feedback that we get from our providers, feedback we get from our members, helps push us towards improving this program. So like I mentioned, we are moving towards a different authorization process as one of the many things that we can improve on still. This service is needed highly, obviously, and we want to continue to support it in the best way that we can. And we understand there's going to be hiccups along the way and always room for improvement, but that's what we need to work towards, and that's why things like this are important to attend. So when you get these invitations to attend these things, come to these these talks, these discussions, and we welcome your feedback as well, right? Any input or ideas that you guys have to better improve these processes, community partners that you know of out in the community as well, we're happy to hear about, because if they're doing work out there that we don't know about, we want to hear about it.
Ask one question before we go to Atlanta. Just, Tessa, do you have any advice for if, whether it's a patient or somebody doing a referral, if they haven't heard back about that referral, what they should do?
Call, ask for me. ask for the program manager for community supports, ask for care management intake. Someone is always answering that phone Monday through Friday, 8:30 to 5:30. We have multiple languages that we speak. The members can call, caregivers can call. We're happy to look into those referrals for you. We can explain where the gaps are. We can expedite those referrals. So don't hesitate. Don't wait on the provider. Don't settle for we're waiting to hear back. Take that extra step. Get directly connected with the plan. We're never going to tell you that, oh, you have to call your meals provider. We will support you in making sure that you get those services.
So one of the things that we try to do with anybody that we're contracted with to provide these services for any of our community supports is to submit reauthorization requests 30 days prior to expiration. So we do have that also kind of built into our provider platform. So once they are 30 days out from that authorization expiration, the button will become active. So hopefully that's, they should be checking that. They should be priming themselves for that. But that is something that we make the request that those come in 30 days prior. We do also experience delays, so I want to make sure that Tessa doesn't feel on an island alone. It's something that we're all actively trying to improve. Things for advice. Number one is, similarly, you can always call. We also have Calium referrals at anthem.com, which is our secure email. You can always inquire about the status. That's managed by our care intake team, Monday through Friday. So they'll be able to review that. One of the things I also just wanted to highlight is for anyone who's working with individuals and wants to support referral processes, from what I've seen is, many of the providers are very open to kind of doing in-services, talking about their services. I think one of the great things that's really helpful is if you generate that relationship. We were talking about earlier is you can actually just say, call up that person, call up that provider, have a patient, want to make that warm handoff and submit that referral. I think some of the things that does help as opposed to, sometimes having more of a cold call, the patient isn't aware that they're going to be getting a phone call from this individual. It just kind of creates a little bit of a more warm handoff, and so everyone's really kind of primed, if you will. So I think those are some of the additional just kind of recommendations.
Thank you. What do you want? I was going to ask that one. Yeah. One more question for Tessa and Alana. Do you all have any, are there any anticipated changes that health plan members or people doing referring can anticipate with, the Calium waiver potentially expiring and this kind of being an ILOS more generally, or will it stay pretty much the same?
We are going to do our best to continue to provide services as they are today. Yeah, plain and simple. We know it's a highly utilized and needed service, and it is at the top of our list.
So I think two things. Number one, plus one to what you said, or maybe I have three things. Number two, these services are available for individuals that are enrolled in managed Medi-Cal. It's critically important now more than ever that we make sure people maintain their coverage, or else they won't be able to take advantage of these services. So to the degree that everybody is working with these populations, there's information and resources about how we can all kind of support individuals to make sure that they don't lose coverage. So that's just something that I'll plug that I will always put in. And then I think finally we've gotten some additional billing codes, if you will. So that will allow us to be able to look at the different interventions that are available under medically supportive food and be able to kind of see their effectiveness of different interventions. So I think from an evaluation perspective, which is obviously the state is always looking at cost effectiveness, that's something that managed care plans do as well. So I think there will be more of a look into that as we kind of move forward. But I think getting those new codes to really kind of assess and look at different interventions is also something that's exciting down the road.
Absolutely. Well, we are excited to move into the Q&A portion. So Sophie will be walking around with the mic if you have a question. And just encourage you, please just ask one question. If you have multiple, hopefully we'll have a chance for folks to get to ask more than one question if there's time. Awesome.
Yeah, thank you so much. My question was about the SF Health Plan. You had mentioned that Meals on Wheels used to be a partner and no longer was, and I was just curious what happened there and any lessons learned or...
Yeah, good question. So as part of our program monitoring and oversight, we look at is what we're giving to the providers sustainable for them as well, right? Providers need volume in order to continue to operate their programs because we reimburse at a certain rate. Because Meals on Wheels offered frozen meals, we did some analysis with them, and it was just kind of determined that we didn't have enough utilization of our membership requesting that meal type, and it just wasn't sustainable for them to continue as a partner. Yeah.
I also had a question for SF Health Plan. Hi, my name is Dana. I'm a registered dietitian at 18 Reasons, and I did have a question about, because I know that there are a lot of local organizations that do want to join into San Francisco Health Plan as vendors and, provide that support. And I was wondering if there are any challenges in adding any new vendors or any local vendors in particular.
That is a great question, and I am very familiar with Sarah, who has been awesome in asking to partner with us. And I've made this recommendation to a lot of local agencies that get with Partners in Care. Because we are looking to partner with them and we have kind of paused indefinitely on new contracts because we're monitoring utilization and they're already in the pending process of contracting, work with them to see if you can possibly be a subcontractor. Because that's a very easy way to become a provider with us, but indirectly as part of what's already in process.
Hi, y'all. Thank you for all the work you do. I think this example that we're talking about, and again, I'm so sorry you had to wait for food, and thank you for coming, and thank you for bringing your babies. They're adorable. Just FYI.
Everybody can get their time with them.
Okay.
The more you guys touch them, the less I have to.
I love it. Bringing support dogs for us, that's amazing. That part of this conference is improving the food system, and I think this example is, this is a demonstration. There is such high levels of inoperability, I guess it is, right, between the healthcare systems and people not knowing about these services, not referring, and it's new and it's out. What can we as advocates and the city and county of San Francisco do to support and really advance medically supportive food and nutrition?
Oh, that's a great question. What do you think? I look to you. I'm like, there's so many different things, right? Doing things like this. going on social media, posting on Instagram, Facebook, all of those things. We've had a lot of providers posting things on LinkedIn, even, and there are a lot of people are on social media these days. Contracting or reaching out to ECM providers or other CBOs in the community and saying, hey, how do we work on direct referrals with you? How do we partner with you specifically to connect with this meal provider to, maybe the ECM provider is a high utilizer provider, and they work with a lot of people that are CKD or have, other chronic conditions. We've had people come to us and say, how can we start a pilot and focus on people with certain conditions because we offer these meals? And pilots turn into long-term programs. And we will do member data mining with you to pull lists of members that may be eligible for those services that qualify. And then it's a matter of just doing outreach and engagement, and in different modalities as well. It's more than just a phone call. If you've got a member address, mail a letter, mail some health information, send a text, knock on their door with the flyer. Anything that you can do to kind of reach these members and meet them where they're at.
I was just going to add, and maybe I'll ask you a question while I'm up here, but, I think what's really important, especially as we're trying to look and get these, these processes integrated into the healthcare system, education is one thing, but, there has to be a level of systems change in order for that clinic to make that referral. They have to figure out who's going to be making that referral, at what point is that assessment being made, and there's a lot of opportunities to more streamline that process. So I guess, Maria, one of my questions for you, to refer out, did you change anything about your process, or is it just kind of part of your regular always workflow? Like, how do you make the determination to refer a member for CalAIM for medically tailored meals?
I look at the clinical picture. I look at all the things that could affect the clinical picture. So if somebody's saying, I have food insecurity, even though the programs are not meant to address food insecurity, I am aware that that's a limiting factor for them to make dietary changes. Then I look at, obviously, the trend of their health markers to see if there's been any improvements or not. And then I make the referral. To answer some of the questions there, I think it's also making the awareness within the clinics or within the settings that you are. So like if you have management level disseminating the information, at least in primary care, they were made sure to disseminate the information amongst physicians so people knew what services were available. And then if you're insecure about what type of services, like for example, the frozen meals would be, check out some of the sites. We took a tour to Project Open Hand, which is one of the contracted vendors, and sampled their meals. And it turns out we really liked them. And so we had a say when patients were like, I don't really care for a frozen meal. Well, I can tell you that I would eat this food. And so that makes a huge difference. So reaching out to some of the vendors or testing some of the foods, involving management into, and then, like I said, being creative as in who would be the people who could start with the referrals, and then how can you make this easier and sustainable?
No, that's great. Yeah, I think kind of looking at that system change, and it looks like you put all the practices, and I know you highlighted having champions really to kind of advocate this as a part of kind of patient flow and referrals.
The referrals don't take a lot of time. They take less than 5 minutes. And actually learning that we can just call has been very, very cool, actually, because we don't have to fill out a form. But so just exploring different avenues that might work for your organization. And then if you have an advisory committee where you have patients, maybe getting them involved as well.
I just wanted to throw in, because this acronym has been thrown out a couple times. ECM is Enhanced Care Management, and it's a different part of CalAIM that many clinics at the Department of Public Health, as well as member clinics with the consortium, are part of. So they're like, they basically are case managers, but in like a more in-depth way and more involved way than a lot of like the traditional case management, and it's billable. So that's what that program is, in case you're wondering.
And I will just add one more quick thing, which is that at the state level, we are continuing to advocate to the legislature, to the Department of Healthcare Services to continue these programs, to expand them or sustain them. So there's on the California Medically Supportive Food and Nutrition website. You can sign up for email alerts. We hardly ever send them, but we do when there's an opportunity to take action. So if you can call or sign on in support of, let's say, this resolution that Assemblymember Miabanta is championing, or potentially this Assembly Bill 2348, that's just another opportunity for advocacy. And I will say in our experience, and I don't know, Lana or Tess, if you've ever done this. Oh, yes. Yes. Yes, 2348. We have found that the Department of Healthcare Services, which again is the state Medicaid agency, to be quite receptive to getting feedback about how to improve the guidance of these services. So again, we're working in coalition statewide to do that, but just another kind of opportunity for continuing and improving the services.
Hi, I know you don't have a lot of numbers yet and it's relatively new, but I wonder if you know who you're not reaching.
In general, I would say like the delivery of services definitely skews older, which I mean, it kind of makes sense, perhaps I would say. I know in some counties I've seen it, it's a little bit more, there's a little bit more like pediatric populations. I think that's an area of opportunity. We do have dashboards that look from language, primary or preferred language, race, ethnicity, and kind of do breakdown overall of who's receiving community supports. I know of Area Focus is also looking from zip codes, understanding kind of the different areas within San Francisco, so is Bayview, Mission, are all those getting, equal distribution of services. So I don't have this snapshot right now, but those are all kind of markers that we would definitely, are looking into and would be happy to, provide further information on. And I think also one thing, the state also has a dashboard that they make available on CalAIM services overall. And so you are able to drill down by, usually by county. You can look at some demographic details. You may not be able to specifically look at, medically tailored meals, medically supportive food. It just may give you more global community support. So it's a little bit limiting in that respect.
Yeah, for us, for sure, it's the pediatric population. We don't get enough of that, and we know that it's out there. Another one that I don't see enough that I wish I did were cancer patients, the terminally ill that are on very specific modified diets. I don't see a high volume of that, and unfortunately, I know it's out there. So trying to figure out how to channel in on that population, however we look at, our hospital census or our chemo treatment claims, those kinds of things, and maybe partnering in that way. So things we're starting to think about.
Sorry, one additional thing, I think looking also at the pregnant postpartum population. I know 18 Reasons does nourishing pregnancies, so I think that's also a very specific population, and I think we're also trying to drive increased collaboration with WIC to kind of facilitate identification and referral pathways.
One thing when it comes to Medi-Cal enrollment, which we talked about, that's very important right now, which is that people who are pregnant and 12 months postpartum have a lot of the changes that are happening at the state level to Medi-Cal are not impacting that population. So there will be less drop off of people on Medi-Cal in that population than maybe in some others.
I would like to add kind of like a thought and a question. So for the demographics that are being missed, is there a possibility that they're being missed, one, because of lack of advertising, and two, because most of the programs that are being offered are tailored for seniors, cancer patients, moms, so what I'm trying to say is maybe some of the people and some of the demographics are being missed and are not showing up in charting because originally these programs were tailored for certain type of clients, certain type of patients, whether they're super sick, super old, or, are pregnant. I don't fall into any of those except for once I got diagnosed with Crohn's, super sick. But up until then, I would have never known about, like, I was with Christina before I had Crohn's. I would have never known about any of these programs. Honestly, once I got diagnosed with Crohn's, more doors opened up of knowledge of what I can utilize, which is unfortunate because I should have known that before being diagnosed. So I'm wondering if maybe some of those are being missed because, like I said, lack of advertisement, and because these programs push and advertise that they're tailoring to a certain clientele. And maybe we would see more numbers evenly across the board if we could include everybody, or at least try to by, seeing if they qualify in other ways other than just having a terminal disease, being old, or being pregnant.
Thank you. So the DHCS criteria today is very vague, I feel. Their criteria is anyone with a extenuating, a severe mental health disorder, and chronic conditions, including but not limited to the following 20 conditions, right? CHF, hypertension, diabetes, CKD, birth equity, many, many more on the DHCS policy. So I think something the plans can improve on is that data mining piece of pulling, the many hundreds of, what are they called, ICD-10s now? The number just keeps going up every 5 years. Pulling those multiple chronic conditions and saying, like, where are these populations at? How many of these folks are actually receiving services, and who meets criteria? So there is some proactive approach that plans can do to be more inclusive.
I also feel like this could be a good opportunity to specify or clarify what the qualifying diagnoses are. For example, if you look at the referral form, it says CAD, but that could be quite extensive. So providing a little bit more education on like which conditions fall under that umbrella would be helpful for other people to use the referral.
So I'm wondering if you all have like one flyer or different flyers depending on the health plan, because like I work at Glide and we're working to become an ECM provider, but we're not currently. So right now it would be more a matter of like maybe letting clients know that this exists so that they can talk to someone else about it, or perhaps our own like case workers trying to navigate the system themselves. So I'm wondering if there's any sort of flyer for that, or training that can be done, or things like that for non-clinic or medical or ECM providers right now.
Yeah, I mean, there's a lot of convening opportunities that still exist. So for any of you all in the room, you all would be more than welcome to attend. They call PATH. What is it? Collaborative Planning. Yeah, I'm trying to figure out the acronym, but I don't know. Yeah, and those are going through the end of the year. It's a great place to meet with other providers, but also it's a really good opportunity to kind of learn about new changes, review policy definitions, and kind of get better insight into kind of more of the finite details about the different services. I do think that having a single flyer, there are 3 managed care plans in San Francisco. Something that we've done in Sacramento is that we have created a single flyer that has all the managed care plans information on it for community supports to facilitate that referral process. We've also done it to have one single like enhanced care management referral form. So I think that's an area of opportunity that we can definitely explore. But if you have questions, just reach out to either of us. We are constantly doing road shows about like what CalAIM is, 101s. That's part of our job. So, obviously from the numbers, you can see that we have a lot of opportunity.
I think
maybe we have time for one more question. Oh, Tessa, yeah.
Oh, I was just going to add also as part of your onboarding process as a new ECM provider, you are given those one pagers for us for this community supports, along with a link to the referral forms for cross collaboration. And we do offer a bi-monthly ECM CS provider, all provider meeting that we encourage everybody to attend because we give updates on both services as well as we highlight new providers.
Do become an ECM or anyone as a community supports provider, the consortium also has a monthly ECM CS provider meeting that we run.
I think probably.
It'll be a quick question, I promise. I'm Sasha from Fresh Approach. I was wondering if you guys could explain more about the diagnoses that let people receive medically supported food and nutrition within like mental health conditions.
Oh, that's a loaded question. We should connect offline about that one for sure.
Okay, then maybe one more question, if that is the answer.
Hi, my name's Olive from Booker T, and I'm just curious about like different education opportunities that you might offer clients, and is that something that like your providers or like partner organizations do, and is that like on an individual level, like to treat specific diagnoses, and like what are some examples of like some things that have like worked for clients?
I was going to say the chart that we passed out has some of that information. So what's kind of available by different providers today, and it is typically medical nutrition therapy, which is one-on-one between the participant and a registered dietitian nutritionist. That's, I think, what's most commonly offered today in San Francisco across both health plans. 18 Reasons, which is contracted with Anthem, they're online, I believe, cooking and nutrition classes that are weekly, where you're cooking actually with the instructor. I know some other groups like Fresh Approach also do online classes who will soon be, I think, contracted. The food pharmacy program that we support, which is also hopefully soon to be contracted, does various types of kind of in-person group education. So that's at clinics. It's a clinic-based program. So it's, yeah, there is a range. And I think one of the things that a statewide coalition that we're a part of is working on is helping to provide kind of different questions or almost decision trees. So if you were talking to someone about getting referred to these services, you could ask them like, oh, are you interested in some sort of nutrition or cooking education? And would you prefer that to be in person or online? Or would you prefer it to be one-on-one or with a group, to kind of help almost them kind of assess, or you assess which provider might be a good fit based on what they're interested in. So we're working on that, and hopefully later this year we'll have that out.
And those sheets that you have, our plan is to update them every 6 months. So new information will get incorporated.
Yes. Okay, I think with that we are at time, and I just want to take a moment to just thank this incredible panel. This has been so wonderful. Yes, thank you. Getting the word out is absolutely critical, and hearing the experiences of folks who've been part of these services is invaluable. And raise your hand if you feel inspired to try to refer someone to one of these services in the next month, let's say. Okay, some people. Okay, well, the people who are excited, talk to someone who didn't raise their hand and give them a pitch about why you think they might be able to do it too. And just, really appreciate everyone's, Yes, talk to Ashley. If you didn't raise your hand, come talk to Ashley. Thank you so much for your time. And I think the whole summit is kind of in its final phases, so I think we all go back upstairs for the closing session.